Pharmacology SAQ21 Drug Interactions. A. What is a drug interaction and how common is it? A drug interaction is a change in the action or side effects of a drug caused by a concomitant administration with food, beverage, supplement, or another drug. About 1 in 6 inpatient drug charts contain a significant drug interaction, 1/3 of which are potentially serious. B. How can drug interactions be classified, and give examples from perioperative practice for each interaction? Drug interactions can be classified as physicochemical, pharmacokinetic, and pharmacodynamic drug interactions. Physicochemical reactions can be precipitation. This occurs as a dissolved substance is separated out from a solution as an insoluble solid, such as the interaction between thiopental and acidic drugs such as succinylmetonium, rocuronium, and atracurium. Sodium bicarbonate and calcium, which forms calcium carbonate as the precipitate, and sodium bicarbonate and adrenaline, which forms a precipitate. Adsorption occurs when a drug adheres from a gas, liquid, or a dissolved solid onto a surface. Drugs that adsorbs to PVC includes insulin, GTN, diazepam, isosorbide dinitrate, hydralazine, and thiopental. Thus, PVC infusion sets should be avoided for these drugs to prevent reduced drug administration. Drug chelation occurs when there is an interaction between a metal atom or ion and another species, by which a heteroatomic ring is formed. Examples include sodium citrate, which chelates calcium, deferiprone, which chelates iron, iron or calcium, which chelates tetracycline, and calcium carbonate, which chelates ciprofloxacin or quinolones. Drug neutralization is a chemical reaction in which an acid and base react quantitatively with each other, such as between citrate and hydrochloric acid, and sodium bicarbonate, which neutralizes acids during acidosis. Other physicochemical interactions include trichloroethylene reacts with soda lime to produce dichloroacetylene and phosgene, which are neurotoxic. Pharmacokinetic drug interactions. Absorption. Morphine, petitine, and anticholinergics delay gastric emptying, which reduces GI drug absorption, and acids reduces the absorption of acidic drugs. Adrenaline reduces absorption of local anesthetics. Charcoal can adsorb drugs in the stomach, which reduces its absorption. Metoclopramide increases GI motility, which speeds up the absorption of co-administered oral analgesics. P-glycoprotein pump drugs back into the gut lumen, decreasing their absorption. Substrates for PGP includes calcium channel blockers, cyclosporine, dabigatran, digoxin, erythromycin, loperamide, PPIs, and tacrolimus. Drugs which induce PGP such as rivampicin and cyclosporine reduces the bioavailability of PGP substrates. Drugs that inhibit PGP such as amiodarone and verapamil increases the bioavailability of PGP substrates. Distribution. Drugs that reduces cardiac output such as beta blockers and volatile anesthetics reduces blood flow carrying the absorbed drug such as succinylmetonium to its site of action. This delays onset of action. Drugs that reduces hepatic blood flow such as certain volatile anesthetics slow drug elimination by the liver. Chelation reduces the distribution of toxins such as calcium additive chelating lead and dicobalt additive chelating cyanide. Displacement of drug from plasma protein binding sites increases the free fraction of drug and its effects, such as aspirin displacing warfarin from albumin, valproate displacing diazepam from albumin, and phenytoin displacing warfarin from albumin. Metabolism. CYP enzymes. Enzyme induction will increase the breakdown of drugs metabolized by CYP enzymes. For example, dexamethasone reduces the duration of action of vecuronium by inducing CYP3A4. Conversely, drugs that inhibit CYP enzyme activity may lead to a decrease in metabolism and an increase in plasma levels, such as amiodarone inhibiting the metabolism of S-warfarin by CYP2C9. Prodrugs such as losartan and clopidogrel require activation by CYP450 enzymes, and therefore the consequences of induction and inhibition are the reverse of those drugs that are inactivated by metabolism. This table lists selected substrates, inhibitors and inducers of selected CYP enzymes. Plasma cholinesterase. Drugs metabolized by plasma cholinesterase includes suxametonium, mivacurium, ester local anesthetics, and acetylcholinesterases. Anticholinesterases inhibits all types of cholinesterases, thus prolonging the effects of drugs metabolized by plasma cholinesterase. Hepatic blood flow. Certain volatile anesthetics, such as sevoflurane, reduces hepatic blood flow, and this reduces hepatic drug clearance. Excretion. Sodium bicarbonate will make the urine more alkaline, which enhances the excretion of weak acids such as aspirin and barbiturates. Probenecid inhibits tubular secretion of penicillin, and this increases penicillin plasma levels. Pharmacodynamic drug interactions. Summation. The action of two drugs are additive, but each has an independent action of its own. Examples of summative drug interactions includes the MAC of inhalational agents, analgesic and antipyretic effect of aspirin and paracetamol, BP lowering effect of amlodipine and atenolol, hyperkalemic effect of ACE inhibitors and spironolactone, hypoglycemic effect of glibenclamide and metformin, bronchodilator effect of ephedrine and theophylline, risk of upper GI bleed of NSAIDs and steroids, proarrhythmic effect of macrolides and quinolones. Synergism. In this drug interaction, the combined action of two drugs is greater than that would be expected from a purely additive effect. Synergism is seen between GABA-acting drugs such as propofol, thiopentol, and etomidate with opioids for hypnosis. Propofol and remifentanil act synergistically. Midazolam and propofol also act synergistically. Other examples of synergism include milrinone and adrenaline for their positive inotropic effects, and various analgesic combinations such as NSAIDs and opioids and alpha-2 agonists, opioids and LAs, and opioids and ketamine. Infra-additive. In this drug interaction, together the individual doses of each drug are slightly increased to achieve the same effect, such as ketamine and midazolam for sedation. Antagonistic drug interaction occurs between two or more drugs that have opposite effects on the body, such as flumazenil, reversing the effects of benzodiazepines, naloxone, reversing the effects of opioids, alpha-1 blockers, reversing the effects of alpha agonists, and ethanol, antagonizing the toxic effects of methanol. Potentiation occurs when the action of one drug is amplified by the addition of another, which has no independent action of its own, such as probenecid, reducing the renal excretion of penicillin, thus increasing penicillin plasma levels and its activity. C. How would you investigate whether the effects of propofol and remifentanil infused together are simply additive or synergistic? The effect of propofol and remifentanil infused together can be assessed using an isobologram to determine if their interaction is additive or synergistic. An isobologram describes the combined effect of two different drugs, with x-axis being the dose of drug A required to produce a constant clinical effect, and y-axis the dose of drug B required to produce a constant clinical effect. Line A represents the linear relationship of additive effect between drug A and B, such that less of drug B is needed as the dose of drug A is increased to produce a constant clinical effect. Line B is an upwardly convex curve that begins and terminates at the same point as line A, which represents inhibition or infra-additive effect, as at any given dose of drug A, more of drug B needs to be given to maintain a constant effect. Line C is a downwardly convex curve that represents synergy, as less drug B is required at any point compared with what would be seen with an additive relationship to produce a constant clinical effect. Additional information. The drug interaction between propofol and remifentanil has been described by an article authored by D. Kopot in 2015 and in another article by S. E. Milne in 2003. Thank you.